Today, we'll focus on screening for early detection therapies for cancer, emerging trends in immunotherapy, and how COVID impacted cancer patients in our communities. I'm Mohini Suchanti, and I'm very glad to be a wellness champion at CWC. It's truly amazing to see CWC ramp up in the recent years and have a range of offerings available in the community. So without much ado, let me please welcome Dr. Sangeeta Agarwal. Sangeeta Agarwal has been a strong supporter of CWC. She's been a regular contributor with her enriching talks and impactful series on cancer care for the community. She's Assistant Chief Hematology Oncology at the Santa Clara Valley Medical Center, Chief Medical Information Officer at Scry Analytics. She's the board certified hematologist and oncologist, and many accolades to her name. She's a member of ASCO, ASH, AMA, AAPI, many others with 25 years plus experience. Over to you, Dr. Sangeeta Agarwal. Very happy to have you on board today.
Thank you, Mohini, for the kind introduction. And it is my privilege to be a part of CWC Crack the Wellness Code. So in this session, I would like to actually focus on two very current topics in cancer care. And nothing is more current than the pandemic of COVID that we're all going through at this time, which is really changing our lives significantly. So, like I said, I'm going to be talking about the impact of COVID-19 on cancer care. So COVID-19, as we know, is defined as an illness caused by a novel coronavirus. Basically, it stands for severe acute respiratory syndrome, coronavirus 2. This was first identified in Wuhan city in China, and the first case was reported to WHO on December 31st, 2019. And in January 2020, WHO declared COVID-19 as a global health emergency. And very soon after, in March 2020, WHO declared COVID-19 as a global pandemic. And since then, this has been one of the most devastating pandemic, and we have not been able to get out of it yet. As of November 11th, 2021, more than 252 million cases have been reported worldwide, with more than 5 million deaths. In US alone, more than 47,000 cases have been reported, with little over 780,000 deaths. So with such a significant impact, there is a lot of advances have made in the treatment of COVID-19. The vaccine against COVID-19 became available for general use in December 2020. And since then, the use of vaccine has increased in both general population as well as in cancer patients. With this, I would like to actually talk about the impact of COVID-19 in patients with cancer. Since patients with cancer have compromised immune systems and are at very high risk for catching other infections, there is a big concern that cancer patient may be at a greater risk for getting COVID-19 and the complications from it, including increased chances of death. These concerns were true in the initial data, but however, with new data, the factors that have been most consistently linked with increased risk of severe disease and death in patient in cancer kind of mirror with those in general population. So with that, I mean male sex, older age, history of smoking, obesity, hypertension, heart disease, and diabetes are associated with higher risk of complications and death, with an exception of lung cancer and hematologic malignancy, where the risk of complications from COVID and death is higher than general population. Moreover, because many of the cancer patients are immunosuppressed because of the disease itself and chemotherapy. They actually are not able to shed the virus. They're not able to actually clear the virus that rapidly as immunocompetent people, and may remain infectious for a longer period of time and shed the virus for a longer period of time. And that may lead to development of multiple variants. So we do not know exactly the impact of COVID-19 on cancer patients so far. NCI has initiated a COVID-19 study in cancer patients called NCC-APS. The study is ongoing, and a full impact probably will be seen in some incoming years. So just to let you know, I think the biggest impact of COVID-19 has produced on the screening of cancers. Screening was most affected during this time. Between March 2020 and end of April 2020, the screening for breast cancer with mammograms, colon cancers, lung cancer, prostate cancer dropped by almost 80 to 90%. In June, it started to recover, but even now, the screening is actually about 20 to 30% lower than from pre-pandemic level. And the full impact of COVID-19 pandemic, like I said, on early detection is still not fully known. So we believe that maybe the cancer mortality may increase as a potential impact of COVID-19 on cancers. And that may be related to a few factors. And first of them is reduced access to the care. And initially that was because of the lockdown and shutdown, but also because of the fear of infection and reallocation of the resources, the access of care is limited. And we have seen that in screening. COVID-19 has also led to unemployment and the financial insecurities and insurance losses. And that also has led to the limited access to healthcare. And obviously social distancing and shutdowns have also led to the limited access to the healthcare. The second factor is delayed routine care, leading to fewer preventive visits, screening, abnormal test follow-ups, as well as symptom follow-ups. So as a result of that, patients are actually presenting at the later stages of the diagnosis, and that reduces the probability of survival. There are fewer treatment options available at this time because of reallocation of the resources. And many of the treatments have needed to be modified, again, due to the risk of infection and also possibly the impact of COVID-19 on general health of the patient and their loved ones. There have been delayed treatments, such as in the beginning of pandemic, many elective surgeries were postponed. The radiations and the chemotherapies were postponed. Less intensive chemotherapies were offered to the patients, again, to prevent any chemotherapy-related complications and the complications related to COVID-19. All might lead to potentially increased cancer mortality, although we do not know the full extent of the effect of pandemic on cancer mortality yet. So because of COVID-19 pandemic, some adjustments were made during the cancer care delivery. And the most important one was the emergence of telehealth. Both televisits and video visits are being widely used. In the beginning, the practice, and this was the guidelines provided by ASCO and other cancer societies, to limit the staging procedures and do only studies that would actually give us information to develop the treatment of the care plan of the cancer treatment. Some of the patients were able to switch chemotherapy from IV chemotherapy to oral chemotherapies so that they can decrease the visits to the clinics. We also try to reduce treatments that lower the blood count and increase the use of medications that will increase the blood counts and use antibiotic prophylaxis, again, to lower the impact of another health issues in these patients. We also try to use treatment that will require less frequent visits to the healthcare facilities. Many patients who were in deep remissions and actually getting maintenance therapy chose to stop the maintenance therapy during this time. Many healthcare facilities limited the visit of companions to the patients to the healthcare facilities, and all of them impacted the health of cancer patients in some way or the other. Later on, with the availability of wide use of screening for COVID-19, that actually happened probably in late April and May, we were able to bring many patients back to the treatment. And with availability of different treatment strategies and understanding of treatment of COVID-19, the rapid initiation of the treatment for COVID-19 happened in patients who were actually who were diagnosed with COVID-19 along with cancer. So in these patients, we started using remdesivir early on and used monoclonal antibodies early on to, help them recover from COVID-19. But nevertheless, these adjustments were made, and the full impact is yet to be seen. I think many services were greatly impacted and delayed during this pandemic. Most reported delays were seen in in-person provider visits, which were down by 57%. Imaging services were down by 25%. Surgical procedures were delayed or down by 15%. The other areas were also impacted, such as access to support services, including physical therapy and mental health care services, were also reduced by 20 to 25%. And we also saw a significant reduction in enrollment in clinical trials for cancer patients. Up to 60% of the research programs were halted and enrollment were actually reduced. On the other hand, televisits and video visits were surged by over 90%, which was in some ways good, because with these patients, many patients actually adhere to their schedules and their appointments with the healthcare providers. So with that introduction, with the emergence of vaccination and availability of vaccine, I would like to quickly go over the guidelines for vaccination in cancer patients. There are multiple vaccines available right now. 3 of them are FDA approved in United States. The 2 are mRNA vaccine from Pfizer-BioNTech and Moderna. And in US, J&J, and in the rest of the world, AstraZeneca vaccines use a different technology which carry adenovirus as a vector that carries a viral DNA. So these vaccines are extremely effective. The efficacy of these vaccines are never been seen before in any other type of illnesses, and they are perfectly safe. I just want to make sure that everybody understands that these vaccines do not contain any live virus or the part of the virus. These are synthetic vaccines and do not risk contracting the disease in immunocompromised or immunosuppressed patients. So these are completely safe. There are some side effects that I will discuss later, but overall, these are the safe vaccines and do not cause COVID-19. I cannot stress this enough, because even today in my clinical practice, I encounter at least one patient who has not been vaccinated and hesitant to get the vaccine. So I just wanted to make sure that these vaccines are safe. There is a concern that the vaccine may not be as effective. Overall, these are quite effective. The recent data from European Society of Medical Oncology was presented in September 2020, which included a study of over 1,000 patients. And it proved that both mRNA vaccines are quite effective, up to 80 to 90%, which is almost parallel to general population, where these vaccines were almost 99% effective, they looked at the antibody response. They did not actually talk about the COVID-19 disease in these patients. However, there is data emerging to suggest that immunocompromised patients may have limited antibody response, particularly in the patients who actually have hematologic malignancies or getting treatment with monoclonal antibodies that actually work against many of lymphocytes or the markers that actually, or the molecules that improve immunity. So one of such drug is Rituxan. And in patients who have hematological malignancy or on immunosuppression therapy or getting monoclonal antibodies, their responses is blunted. And based on this, actually, NCCN, which is National Cancer Care Network, created a COVID-19 vaccine advisory committee. And this committee made some recommendations for vaccines. The biggest and the most important recommendation is patients with active cancers and those on the treatment should be prioritized for the vaccination since it is quite effective. Immunization is recommended for all patients receiving active cancer therapy. In patients who are getting bone marrow transplant or getting CAR T therapy, we recommend to delay the vaccination by 3 months, mainly because they may not mount a strong response to vaccine and may get a false sense of security. If not possible, then it's better to give vaccine than not. The eligible caregivers and household contacts should also be immunized whenever possible, as soon as possible. And the committee also supports the use of any available FDA-approved vaccine, whether it is Pfizer, Moderna, or J&J vaccine, to every patient who is eligible. NCCN also supports the mandate for healthcare workers that require, vaccinations. So now, with that, I'm actually going to talk about the third dose recommendation, and I think there is some confusion about it. Third dose is different than the booster. So the booster of COVID-19 is given after 6 months of the last dose. And that's when it is seen that the immunity from the vaccine is waning and the booster is given to boost the immunity again. The third dose is different because in cancer patients and patients who have impaired immune system, such as after the solid organ transplant, mainly kidney transplant, they have shown that their antibody response to 2 doses of vaccine is not as robust. And after the third dose, their antibody response was as robust as in the other populations. So the third dose is recommended for these patients who may be immunocompromised. And the CDC definition for these immunocompromised population is patients with active cancer who are receiving active treatment, the recipients of organ transplant taking immunosuppressive medications, the recipients of bone marrow transplant within the last 2 years, patients who have primary immunodeficiency syndrome, which have congenital immunodeficiency syndrome, patients who have been on steroid therapy that may suppress their immune system, and patients with untreated or advanced HIV infections. So in these patients, CDC recommends that an additional dose of mRNA COVID-19 vaccine must be or should be administered at least 4 weeks after the second dose of the mRNA vaccine. The current recommendations are for the mRNA vaccine. The data about J&J and the AstraZeneca vaccine is not clear. And right now, the second dose of J&J is actually being recommended, but not completely for the same indication. The J&J second dose is recommended for booster, but not to improve the immunity. So I would say even in the patients who have gotten J&J vaccine, we're recommending to take mRNA vaccine at least 4 to 6 weeks after receiving the last dose of the vaccine. The CDC does not recommend use of antibody titers to determine who should receive the third dose. Anybody who is who qualifies according to the CDC guidelines as an immunocompromised patient should receive the third dose of COVID-19 vaccine. And patients who actually have received COVID-19 vaccine before, but still developed COVID-19, we still recommend third dose of COVID-19 vaccine after they have recovered from it and cleared from the COVID infection. So these are the guidelines from CDC. The vaccine response, even with additional dose, may not be sufficient to prevent infection in the immunocompromised patients. So we do recommend that even after receiving the third dose, immunocompromised patients should actually use caution and avoid crowds, large public gatherings, and limit contact with people outside their household, and especially limit the contact and interaction with unvaccinated individuals as much as possible. So even though vaccines are safe and effective, the efficacy may not be as robust as in general population. There are some side effects of the vaccination, and one has to keep them in mind. And one of them is lymph node enlargement. So the lymph node enlargement has been reported in about 16% of the patients who received COVID-19 vaccination with the mRNA type vaccine. This is completely benign and reactive and does not pose any risk to anybody. However, it may confuse the results of imaging, and especially in the early on in the vaccination days, many patients end up getting biopsies of the lymph node, mainly breast cancer patients who actually had mammograms and ultrasound and found to have lymph nodes and ended up getting the biopsy. So now the radiology guidelines are recommending to postpone breast imaging 4 to 6 weeks after completion of COVID-19 vaccine, if possible. If not possible, then we have to keep in mind that lymph node may be benign or reactive, and then repeat the imaging maybe 4 to 6 weeks after later. And then there is a very, very rare complication of post-vaccine thrombosis with low platelet count. It is mainly seen with the J&J and AstraZeneca vaccine, and it is fortunately extremely, extremely rare. This same complication is seen with COVID disease and much more common. So I would not recommend that anybody deters getting vaccination because of this complication. So in the end, our parting advice is still now the vaccines are available, it is safe. So get screened. It is safe to resume regular cancer care screening and care. Get vaccinated. Vaccines are safe, effective, and the only way out of this pandemic. And continue to be cautious, wear masks, wash hands regularly, and be cautious about interacting with people outside the same household and people who are not vaccinated. And do resume your regular treatment and preventive care. And with that, I thank you all for your attention. I would like to keep this session interactive, but maybe we can hold the question and answers till the end of the session. This is the end of my presentation. And with that, I would like to introduce Dr. Shiva Singhal. So I'm so privileged to share the podium with Dr. Shiva Singhal. She is an attending physician at the El Camino Cancer Center. She is she got her she's an MD and MPH, has a master's in public health. She received her fellowship from University of Missouri in 2012. She was the medical director in oncology in the Digny healthcare system, and now has been practicing at El Camino Cancer Center for many years, and really very, very passionate about cancer therapy. So she is going to talk about another current topic of immunotherapy in cancer care. So over to you, Dr. Shiva Singhal.
Thank you, Dr. Agarwal. Thank you so much for inviting me and giving me the platform to talk about new and upcoming changes in the cancer care, and more importantly, the immunotherapy, which I'm going to talk about. And thank you for an excellent talk on COVID-19 vaccinations and how it's impacted our cancer patients. A really good point that you brought up was all cancer patients should get their booster. And it is, whether you're on chemotherapy or not, vaccination is a must and is definitely important for all of our cancer patients, especially the ones even on active therapy. So with that, let me, let's see, open my slide. So the goals of my talk today is basically to throw a little bit of light on what are the newer therapies that are coming for cancer treatment. Then we talk mainly about immunotherapy today, and then how the environment of cancer care is changing, how we as physicians and especially oncologists are making decisions on future treatments, basically the targeted therapies. So with that, this is basically a representation of how we were doing our cancer treatments before. Until about 2015, prior to that, our cancer treatments were mainly chemotherapies. With that, about sometime other, as research was going on, immunotherapy came in the data how to battle our metastatic patients, how we prevent stopping the tumors from spreading. Also, you will hear a word called personalized medicine, where we talk about antibodies that can be produced and are very commonly being used to destroy the cancer cells. And that would be a little bit, I will throw a light on that as well. And as we see where is the direction of the cancer treatment going in future, and one of them, as I was talking, is basically the immunotherapy. The other aspects of cancer care that is coming in future will be cell-based therapy and epigenetic drugs using genes or genetics for treatment of cancer. I also want to bring out that as nowadays, when our patients are diagnosed with cancer, gone are the days when patients had stage 4 cancers, and we would say, we give them the prognosis 2 years, 4 years. Now, with the advent of immunotherapy, with the advent of personalized medicine, and with the advent of kind of very important field that is radiosurgery or cyberknifing, where which we'll talk sometime later in our sessions, has changed the way we manage our stage 4 cancers and how we have prolonged their life is going to be our discussion. So going on, I'll use melanoma as a prototype for modern immunotherapy that has changed the whole scenario, how we as oncologists, take care of our patients. So this, who doesn't know our President Carter? This was in 2015 when President Jimmy Carter was announced that he's cancer-free. And to note that he had melanoma, he had brain mets, and he was given at that time, it was a new drug, it was in research, and he was given the drug called pembrolizumab. This is one of our very commonly used immunotherapy agents. And how it works and how our President Carter became cancer-free is going to be my talk as we go forward. Now, I want to bring attention to the audience here is in 2014, that was when I would see I still remember seeing a young patient. She had 4 kids. She had been to MD Anderson, Texas, and she was told that this is your 3rd line treatment. And this is it. This is what you're going to get. And she actually died of cancer, leaving her 4 kids behind. This is at the same time when research was going on, and we have President Carter who survived this. Immunotherapy was in research. It was not being offered to everyone, but it was coming out. But this is a scenario I'm trying to bring out how immunotherapy has changed. And now our patients are not only living longer, some of the patients are even getting cured of the cancer. And melanoma is actually one of that cancer. It was a very aggressive cancer. It is still very aggressive, but some patients are getting, the word cure is very hard for stage 4 cancers, but some of our patients are actually with immunotherapy. This is actually a true story, a slide from Dr. Kong, MD Anderson, Texas. And again, this was the time when immunotherapy was in research and the drug was Keytruda, the same drug which is a market name Keytruda, the pembrolizumab. A little bit on the story of this young radio DJ, 44-year-old female. She was actually on air when she had a seizure. She had brain mets that was found at an MRI when she went to the ER, stage 4 melanoma. And she had involvement on the workup found to have involvement of the lungs, of the soft tissues. At that time, the treatment was called cherry picking. Wherever the mets had gone, we would remove those mets. And she had in the lung, she had in the soft tissues, so gamma ray radiation was given, neurosurgery was done for her. As I had just talked a little bit about personalized medicine, we are using genes. She had that MEK gene inhibitor, the mutation, she had that MEK mutation for which she was given that drug called MEK inhibitor. She still progressed, especially in the lungs, did well for some time. But again, after a few, actually 1 to 2 years, she had a progression in the brain mets. That's when time I'm talking about 2015, Keytruda was coming in the market. She was started on pembrolizumab and she became totally disease-free, cancer-free within 18 months of treatment. That's how magical this immunotherapy drug was. And this is a true story of a young girl at 44 who I just told you I had seen a patient in 2014 while I was telling my patient that I'm so sorry, I wish I had a drug for you and had you live a little longer. And I still remember her begging me, could you help me? I want to see my high school daughter graduate. And here is another patient who went through this drug, which was in trials at that time, and she was cured of this cancer, or she became, at least went into remission, and there was a life before her. So with that, this is my slide to indicate what are those cancers where we can use this PD-L1 inhibitor. Actually, the truth is, as I speak, this is actually my old slide when I had presented immunotherapy a few months back. The drug is actually now in studies on every single cancer I can think of. But we have a data-proven phase 3 trials. The prototype, as I started with, is melanoma. Renal cell cancer, it has become a landscape-changing, practice-changing drug. We use it all the time as a first-line therapy. Lung cancers, I cannot think about a patient where we don't start on immunotherapy if they have PD-L1 receptors that's checked and then they're started on. So lung cancer, whole scenario, the landscape of management has changed, whether it is a squamous cell kind of lung cancer, whether it is adenocarcinoma. Again, each cancer, there is a little bit of nuances. Head and neck cancers has come into the front line. Bladder cancer. Bladder cancer patients, I have actually personally seen where I would tell patients, this is it. Now we are using it as frontline, and it has really changed their treatment management, how we now treat bladder cancers, which are really aggressive cancers. Sometimes some patients don't even want surgeries, and they can be offered. I also have to say, when patients are above 80 years old, we used to tell them, I'm sorry, we really do not have any option for you. I cannot tell you, and Dr. Agarwal is right here who will vouch for that. Now patients who are older, who are even 90-year-old patients can at least get some treatment option, and that is immunotherapy. And that is how beautifully this has changed our cancer treatment and management. Another one I really want to point out in cancer is called MSH high tumors or MSI stable tumors. So this is MSI high or MSI stable. These people who have mismatch repair deficient tumors, especially for colon and cholangiocarcinomas. Definitely, if any of your family members or yourself have it, ask for it. Has changed our cancer treatments. Many patients have seen don't even need chemotherapy. They can be started even as a frontline immunotherapy in these patients. The other aspect was triple negative breast cancer, where it has changed, and the list goes on. Now, how does it work? There are traditional cancer therapies and there are cancer immunotherapy. Now, when we were doing the traditional chemotherapy, um, the radiation or drugs were used. It will kill the healthy cells and also kill the cancer cells. What was the problem? It was causing many side effects. Now, when we do chemo, the immunotherapy, it unleashes the patient's own immune system. It kills the selective cancer cells. It actually boosts the patient's own immune system, and there are few to no side effects. So that's how different the difference is between chemotherapy and immunotherapy. What is the cancer immunotherapy principles? A little bit on that. The principle is basically the host immune system is dominant enemy that is faced by the developing cancer. The successful cancers have to overcome the host immune system. The activated immune system can target many tumor antigens together, and that can cure patients with cancer. What are the immune cells which we have in the body which are activated are as named here. And I'll move on to my next slide. Main cell which you need to know is our dendritic cells, which are the tumor, which are the antigen presenting cells, which boost the immune system basically. Now, what are the various organs of immune system in our body? Which our body has multiple sites where, which actually produce the immune cells, tonsils, the thymus. We have multiple immune cells in our bowel, bladder, the bone marrow, and skin. We have lymphatics. We have also in the like a bone marrow, which has the mainly the immune cells are produced. Now, the dendritic cell, as I highlighted, is the main cell, which is a kind of a white blood cell, which is also called antigen presenting cell, which presents the antigen and to the T cells, which is the main immune cell in our body. Most important cell is a T cell, and that T cell is presented by the antigen presenting cell, which are also called dendritic cell. These antigens, what are these antigens? Antigens are small, specific substance which is specific to that virus or the bacteria or the cancer cell or a parasitic cell. And that's brought to the T cell, which is a specialized kind of immune cell in our body. And there is a direct interaction, as you can see, between APC or an antigen presenting cell and a T cell, which has multiple receptors trying to accept and understand and then give us the immunity against those infections or the cancer that is trying to invade our body. So this is actually a very good, very simplistic form of showing, and this is an electron microscopic view, that when a T cell is activated, or T cell in general in our body, we fight our cancer cells every single day, or fight virus, or fight bacteria, and how it does it. So the T cell, as you can see, is here, which is in blue, is activated, and that is attacking the antigen which is on the cancer cell, and it is binding to the cancer cell. And in general, in our body, has the immune power or immunity to kill the cancer cell, and the cancer cell dies, as you can see here. So with that, the next slide tells us how does this immunotherapy work, which is the basis of the newer drugs which are coming in the market and attacking different targets. And if you see the tumor cells, they bind to the T cells. So this is a tumor cell, and this is a T cell. So normally what does the cancer cells do in our body? They are very smart, and they try to switch off the T cell so that our own body cannot fight the cancer cell anymore, and then we get the cancer. So what does immunotherapy do? The immunotherapy drugs block the tumor cell. So here comes the drug, as you can see in green, and this is a T cell, and this is a tumor cell. So tumor cell, as you can see, this cancer cell is trying to kill the T cell and deactivate it, as you can see, off. But the drug, which we call immunotherapy drug, comes in and prevents that from happening. And that is a PDL1, or Keytruda, as you hear very oftenly, or nivolumab or Opdivo, the drugs name which you have heard in the market, do is switching your own immune system back in action again. This is again an immune boost slide, a more simplistic view. And what I'm trying to say is what is PD-L1 or a checkpoint inhibitors, as you read often or hear often in the ads. The PD-L1 checkpoint protein prevents the T cells from attacking the cancer cells, and the inhibitor drugs allows the T cell back to act or back to kill the cancer cells again. This slide basically is trying to help understand what are these new drugs, and there are many different forms. This is a PD-1 inhibitor. So what this shows you that in the market, as you hear, or the newer drugs and newer research is happening. And this is a slide from our New England Journal of Medicine that shows that the tumor cell, which is trying to act, and how the PD-1 or the PD-L1 inhibitor binds. And the name of these drugs, the PD-L1 inhibitor, is atezolizumab, durvalumab, and avelumab. The PD-1 inhibitors are nivolumab, pembrolizumab, and this is another one new in the research. Now, having said that, this was the basis how the immunotherapy works, but the problem also happens with immunotherapy, although there are less side effects as compared to chemotherapy, but there are side effects. The problem with these drugs is too much immune system. So now what we are doing is we are playing with our immune system, right? So sometimes the side effects happens, and the side effects are basically over or too much of immune system activation. So it can affect the brain, and there can be encephalitis. This is the side effect, which is due to the immunotherapy can happen. A very common side effect, which I see in my clinical practice, is pneumonitis. The pneumonitis is inflammation of the lung. The other things that can happen is the hepatitis, and that can cause yellowing of the eyes, nausea, vomiting. The liver enzymes can go up. Kidney problems can happen. Skin problems can happen. Sometimes rashes, itching, painful lesions can happen. Arthritis, that's another big side effect which we see with our immune agents. Joint pains, arthralgias, neuropathy can happen. The other side effect, which is a very common, which I see with my patients, is fatigue. So elderly patients, as I was telling you, can get this drug, especially people who are above 85, 90, can still, who cannot get chemotherapy, sometimes have prolonged life, and can also have remission or the prolongation of their life with these agents. But the main problem which I see with my elderly patients is fatigue. Fatigue and tiredness can happen. That's more or less about the immunotherapy. With that, I think I would like to end my presentation. Immunotherapy is not about just the response rates, it's about long-term survival. So what is changing in the cancer field is now stage 4 patients are living longer because of these agents coming in the market. They are changing our scenario of especially metastatic cancers or stage 4 cancers, as we say. So these patients are living longer. They are, some of them, not everyone, but some of them can be even cured, which we could not imagine in the past. Thank you very much. And with that, I'll give back the podium to Dr. Agarwal.
Thank you, Dr. Singhal. It was a wonderful presentation, very, very informative. And really, immunotherapy has changed the landscape of cancer care treatment in the recent past, and it's still continue to evolve going in the future. As you mentioned, melanoma was the prototype, but pretty much immunotherapy is being used or tested in every different type of cancers. We are realizing where to use it, where not to use it, and what our limitations are. So thank you so much for this presentation. So this is my another role as a medical oncologist. I also have an initiative called Voice of Cancer Patients. This is a platform actually where patients can talk to each other and use their forums. So as a background, cancer care requires multiple facets of the treatment, multiple cancer, any treatment actually is, any patient is not treated in vacuum. It's just somebody says like you need a village to raise a child. Here you need multiple modalities to treat a cancer patient, which includes the family, hospitals, clinic, other caregivers, cancer survivors. And many of these patients want to hear from other patients about their situations, how they're doing. And they not only want to talk to other patients about what they're going through, but also want to validate their own issues and probably want to interact and maybe create a support group. So our aim at voiceofcancerpatients.com is to bring many different types of cancer-related forums on one platform so that the patients and caregivers do not have to search a specific forum for their particular cancer. And it can also allow them to follow the original forum that the answer came from. So it's basically, I can say it's a Google of the patient-related cancer forums. And we also use machine learning and AI techniques to actually analyze what patients are talking about and their reported insights. So many of these forums are actually originating in North America and Europe. And these are some of the names of the forums that I've actually put: breastcancer.org, forum breastcancernow.org, and cancer.org, and such as like that. Most of these forums are actually written by Caucasians for Caucasians, and we don't have such forums coming from Southeast Asians. So I would like to actually offer this platform to Southeast Asians, because every community has significant cultural and genomic differences, and we could like to get some insights as well as their preferences, in regards to cancer care, and maybe correct some of the disparities in cancer care all over the world. So the way this works is we collect the forum data in form of unstructured text, and then use machine learning technology using natural language processing and machine learning to kind of mine this data and then get insights about their cancer attributes, patient attributes, their symptoms, what they're going through, medications, side effects, and other informations. So that is what is different that this platform does, besides providing the forum and the platform to every other cancer patients. So we have used this forum to kind of analyze from Voice of Cancer Patients. Some of the examples are early on, I have presented this data to many international conferences. One of them is analysis of patient concerns regarding the cognitive deficit, which is a chemo brain after the treatment with breast cancer. And actually we found that, chemo brain is how common the chemo brain is, and the insights and the therapies that patients are using to alleviate their symptoms. Another one was association of family history and genetic mutations in breast and ovarian cancer. And we have put all of these things as a small articles on the site. So actually, I'm going to show you how the slide works, and I hope it works. So basically, I'm sharing voiceofcancerpatient.com's website. So this is the screen, the initial screen. I was talking about the breast cancer. So let me actually show you so this is the community here of the patients. Here we have put in articles about various analysis that we have done. These are very patient-friendly articles. These are stories that patients can put on. And let me actually go on the main screen of the Voice of Cancer Patients. I'm not able to go back to the initial page. Okay. Let me see if I can go to the, yeah. So this is how the website actually looks like. These are all the different type of cancer forums. So this give you an aggregate of the drugs, side effects, supportive therapy, and sentiments. So I'm going to actually stop talking about, so I'm going to basically, I want to offer this site to everyone who may have cancer or their loved one who may have cancer. this is a very powerful resource. We have more than 50 million messages from various forums. You don't need to know which forum to go to. If you just ask a question, it will give you answers from various forums related to that type of cancer or that type of drug or that type of side effects, and one can get insights. I'm going to stop this share and then go back to my original one. Let me see. Okay. Okay, and then in the end, I would like to just talk to you about future directions where we're going. I'm in the process of creating an online patient navigation system, which will provide the next step for their cancer treatment. So we'd like to blur out the rest of the information. There is a lot of information available for the cancer, but many times patients get very confused with all this information. So this navigation system will provide the next step in their cancer treatment. And these are the validated steps taken from NCCN and ASCO guidelines. And we are also going to link the local resources for that particular stage and type of cancer. So it is in production. Stay tuned. Maybe next time I will show you some information about it. And this is the end of my presentation.
A wonderful presentation. A lot of new information. Thank you for sharing all of the new research out there. Kudos to you, Dr. Agarwal, on getting the platform ready. Voices for Cancer sounds very exciting, and we'll definitely check it out. So, as others gear up with their questions, I guess one question that I can ask both of you is that you definitely stressed about the immunotherapy being available um, for patients in stage 4. What has been your experience of cancer patients, getting choice for immunotherapy versus chemotherapy? I mean, I guess any patient are presented with several options. So, what is coming from a patient perspective? How do you navigate the various options available for them? What is the best way of gauging that? And then, what are the differences? In like early stage versus advanced stage in terms of immunotherapy? Is that an option for early stages of cancer? So the two questions.
So are you sure you want us, you have another hour? This question is a loaded question. And if you want to answer this question appropriately, you need another hour or two for explanation. But
another, with probably an example, and Samia has of course put out the next session coming up where we can discuss more. But with examples from your own patients, or anonymously, you could talk about gauging the different options always available, right? And that's why I think patients take on multiple recommendations and look at multiple doctors to see that they're getting the best course. But now that that immunotherapy is out there, it's real, it's been tested, research is out there. But you also have this equally effective mode of chemotherapy and radiation. How difficult or easy it is for patients to select their treatment option?
I would let Dr. Singhal answer, since you were presenting on, and I can add on later on if needed. Yeah.
Okay, thank you. To answer your question, I would divide into two groups. One is early stage and late stage cancers. Now, early stage or late stage division is one, then also the type of cancer we are talking about, right? I have to say that for early stage cancers, immunotherapy in general, it is hard to say whether you should take it or not. Every cancer is different. Their treatments are different. And the most of the treatments, we oncologists go by evidence-based. What is the guidelines for that specific cancer? So patients can definitely ask, what about immunotherapy when they go to their physician? They should be aware of that option as an available option. But at the same time, it is, I have to say, it's a landscape changing for more stage 4 than early stage. But most, again, each cancer is different. So generalizing and talking as a platform for cancer would be wrong at this platform for me to say anything. But patients should feel that if they have stage 4 cancer, that is not the end of their life. Actually, now they should feel empowered, I would say, that they have options and they may live long. And Dr. Agarwal would agree with me. I would say that the immunotherapy has changed more landscape of the stage 4 cancers. Having said that, sometimes we use, it's a case by case basis, even for early stage. I have a 90-year-old elderly gentleman. He is bladder cancer and he cannot tolerate chemo. He has PD-L1 positive disease. Would I use immunotherapy? Yes. But if this gentleman was 60 years old and if he had early stage bladder cancer, the treatment decision would be based on his cancer, the type, a lot of different case scenario would come into the play. So I think that would be another discussion. As Dr. Agarwal just said, it will take us a whole session to talk about cancer, and we might have to go cancer by cancer to basically highlight their treatment options. But having said that, this is definitely, and the second most important, which I would end what I'm saying is a personalized medicine or targeted therapy. You definitely should bring out that discussion with your oncologist if you have stage 4 cancer, because the treatment scenario, treatment decisions, a lot depend now on your specific gene mutation, your specific armatorium, what else I can do to prolong life. And many people are living longer. Another thing I would add, I did not bring, my goal was to present how immunotherapy works, is maintenance therapy. That is another changing field of our cancer management, is we now put a lot of patients, and immunotherapy is a part of maintenance therapy in many cancers like lung cancer, like bladder cancers, many cancers. So that is another thing to add. But with that, I'll let Dr. Agarwal add to that, what she thinks in her practice.
I would agree with that, but I would take actually some opportunities to answer some of the questions, and there are a few on question and answer. So Mohan Attawar asked, what tests are used today to qualify for therapies? So the tests generally are used based upon the origin of the cancer. So for example, in breast cancer, we still are using hormone receptors and HER2/neu, but there are tests that we use which are agnostic of the cancer origin. So we use next-gen sequencing testing, and Dr. Singhal said before, PD-L1 expression on the tumor. So PD-L1 expression on the tumor is correlated with response to immunotherapy, and that's one area where we can use that PD-L1 expression to determine who is likely to respond to immunotherapy in stage 4 diseases. Besides that, when we do next-gen sequencing test on the tumor, it actually tell us which are the targets that may be overexpressed, underexpressed, or targetable, and that gives us some more therapy options, which include immunotherapy and maybe other targeted therapies that may specifically target that altered molecule on that particular cancer. And one of the alterations that we look at, as she mentioned before, is MSI, microsatellite instability. Patients who have MSI high tumor respond to immunotherapy. The other one, we look at number of mutations in the tumor. So if there is a tumor which has a lot of multiple mutations, those are considered immunologically hot tumors, and they may respond to immunotherapy a lot better than some of the not. And some of these things are organ specific. So for example, lung cancer specifically is generally considered an immunologically hot tumor. Squamous cell carcinoma that come from the head and neck and the cervix are considered immunologically hot tumor, and they may respond to immunotherapy a lot better than other therapies. There are trials which are looking at a role of immunotherapy early on in early type of cancers, such as bladder cancer, and we are waiting for more data. But because some of the side effects of immunotherapy could be unpredictable and lifelong, one has to be really careful using just immunotherapy just in everybody in early stages who are likely to live for a long time. So I think many of our treatment options are based on the guidelines and the previous experiences that we have. Then there is a question from Srinivas Ramachandra. Can you talk about any cancer specific to South Asian community where immunotherapy has made a big difference? There are no, these are not the cancers specific to South Asian community. These are the cancers that are actually found in general population, which are also true for South Asian community, I would say. So cervical cancer, lung cancer, head and neck cancer, all of these cancer actually respond to immunotherapy in all the communities alike, whether this is South Asian, Asian, or Caucasian, or even an African American population. So here I would not say that there is anything specific to South Asian community. Do you agree with me, Dr. Singhal?
Yeah, and actually, in South Asian community, two cancers come to my mind. One is hepatitis B related hepatocellular carcinoma. And the second cancer that comes to my mind is head and neck cancer, which is actually a very common cancer in Indian population because of chewing tobacco. Squamous cell cancer, as Dr. Agarwal just pointed out, is immunohot tumor. Immunotherapy definitely is a great option, and PD-L1 looking at early time is a good to know. The other treatment, actually, I would like to point out hepatocellular carcinoma. Earlier, just up to about 6 months ago, we were using a drug called Nexavar or sorafenib or lenvatinib as a first-line therapy. You would be surprised now that in the last 6 months, the first-line treatment has changed and can be. It's still ongoing studies, okay? But this is a phase 3 trial that passed using immunotherapy plus Avastin. Is now considered, Avastin is a anti-angiogenesis inhibitor, a targeted therapy against the VEGF receptors of the cancer cells. And that is one of the cancers which is very commonly seen in the Asian community who have Hep B, actually positive disease. So, but there's a lot of nuances to this, but I just wanted to point out hepatocellular cancer is another very big cancer where it's a landscape changing, where we used to use, sorafenib or lenvatinib as a first line, and now even this got first line approval. So immunotherapy is getting approved first line in many cancers. The South Asian population has the only thing I feel the immunotherapy is a very costly agent. It's not, the studies in South Asian population is not like a race based or the Asian population based. It is general based. It is not easily available. If we are talking, if many of our audience today is Indian, it is not as easily available. It's a pretty costly drug. I don't know if you know the cost, but to my knowledge, the monthly cost of these agents is $4,000 per month, just to put it out there, So I don't think it is as easily available. It's as easily used in India as far as I am aware of, but it is coming in a big way, I think, globally. Just to put it out there, but yeah, it is definitely. And I actually want to share one as I end this, where I'm speaking, is I have a 94-year-old grandma, and she was referred to me, and she was having severe abdominal pain. She had a big mass in her stomach. She had a stomach cancer. So our palliative team came and said, why don't we make her hospice? So, and she was bleeding. Her hemoglobin was low at 8. As I said, we Asian population really like to go full force for our parents, our loved ones. And so came the family and said, is there anything, Dr. Singhal, you could do for my mom? I said, see, first thing you should do is radiation. Let's stop the bleeding. So we did the radiation. And then I did what exactly we should do is something called what Dr. Agarwal pointed out, next-gen sequencing. We looked at the MSI receptor and she was MSI high. You wouldn't believe, but this is true. My 94-year-old patient is 2 years out and her cancer is nowhere seen. We didn't use chemotherapy, but I have to say the immunotherapy is what gave her the life back, which I would have said she would have not lived 2 more years. And she lives a great 94-year-old healthy. Asian genes are strong. Some of the patients live long. And she's back to living like a normal mom. This is a really great agent and is being used in every single cancer I can think of, is being researched and seen how we can use them. With that, I would pass on to Dr. Agarwal again.
Yeah. Is the small cancer of bladder is treated the same way as small cancer of the lung? And what is the response rate to immunotherapy? Yes, a small cell cancer of the bladder is treated the same way as the lung, and it would respond to the same type of chemotherapy, which is cisplatin and etoposide. But these days, immunotherapy is approved for small cell cancer of lung or any kind. And I would definitely include immunotherapy. There are a combination of immunotherapy plus chemotherapy that can be used. And if the patient is not able to tolerate chemotherapy, immunotherapy alone is effective. Actually, I have a patient who, again, like Dr. Singles, she's 84-year-old with neuroendocrine tumor, which is a type of the small cell cancer, aggressive small cell cancer. And she is doing amazingly well with immunotherapy alone 1 year out. So again, I mean, we all have examples and anecdotes of the patients who are doing extremely well with immunotherapy. For small cell cancer, small cell is considered immunologically hot tumor, and I would definitely use immunotherapy either alone or in combination, depending on the patient's general health and condition. And then I think there is another question. Let's see, that was in the chat. What is the difference between immunotherapy and targeted therapies, and how these emerging treatments relate to people who are on anticoagulant like Coumadin and might need ibrutinib? So I think I would differentiate immunotherapy and targeted therapy in two ways. Immunotherapy is making your own immune system fight the cancer. It's not specific. It is not specific to the tumor or to the type of the tumor. It is basically killing all the tumor cells if it can recognize. The targeted therapy is slightly different. It is basically taking into account of any mutation on the cancer cells. So if there is a mutation or there is an alteration on the cancer surface cell, every cell basically divides and grows based on some of the markers on the cells or some of the cytokines or hormones inside the cells. And if we can identify one particular alteration and can develop a drug that can attack or inhibit or exaggerate that mutation, that is called targeted therapy. So ibrutinib is a targeted therapy. It is basically attacking a specific agent called Burton kinase, and it is a Burton kinase inhibitor, which is found on certain B cell malignancy like CLL, like some other B cell lymphomas. It cannot be used to treat a lung cancer, right? There is a targeted therapy in lung cancer, which is one example is Tagrisso or osimertinib, which is used if that particular cancer has another mutation in the other gene is called EGFR mutation. So the targeted therapy is specific for a specific mutation. It may or may not be tumor specific, but it cannot be applied generally. Whereas immunotherapy can be applied a little bit more broadly. That would be my answer. Ibrutinib, again, specific to ibrutinib, it causes bleeding tendency. So one has to be really, really careful if somebody is on Coumadin using ibrutinib. And I would look if there is another option available who is on Coumadin. I mean, there are other targeted therapies such as venetoclax, which inhibits another marker in that particular patient, because both ibrutinib and venetoclax are kind of effective in similar tumors. So I think that, and if you want to talk to me offline, we can talk about that. But this is the difference between targeted therapy and immunotherapy from my perspective.
And thank you so much for both of you for coming, taking out time on a Saturday evening for educating us on the new research in cancer therapies, the exciting prospects for later stage cancer patients, and all your overall optimism for all your patients. So it's great to see that, and it's very inspiring for us all.